Guys, let's talk about orthopedic surgery. But first of all, I'm going to show you some important structures which will help you to grasp the injuries and other things very well. And you will be very happy after the class that you had this class. Okay, let's not talk much and let's get into our studies. First thing you need to know, first thing you need to see. A lot of things you have to know from orthopedics, but remember, only the things I tell you are important and are going to come in your exam. Other than that, nothing will come in exam. And if it comes, not only you, but no one will be able to answer. No one will be able to answer. And this is a cut mark exam. Always remember, you must know the common things first. If you know the common things and the things they usually ask in the exams, you will never fail this exam. This exam is very easy if you know what are the things you need to study. This exam is just very easy, very stressful exam. The preparation is tough, but we are here to make it so easy. After the result, you cannot believe you passed. Just follow what I say, you will pass this exam. Okay, we will start with shoulder because the most commonly asked question, and definitely not only in orthopedics, like in orthopedic scenario, but they will ask you anatomical questions. So you will be able to answer all of it from anatomy and from orthopedics too. First thing you know, this is deltoid. We all know this is deltoid. We all know. Now we hide it. We don't need it right now. We need rotator cuff. We need rotator cuff. They will definitely ask you a question from rotator cuff. Always, always, always from anatomy, from orthopedics, wherever you say it, they will ask you a question from rotator cuff. Now, we all know what are the rotator cuff muscles. This is subscapularis. See, look at this muscle. This is in front of your body. As this is in front of your body, I mean on ventral surface, not in front, of course behind, but in front of the scapula. So it will pull your arm internally, internally. So it will rotate your arm internally towards the midline, like this, towards the midline. Okay, this is subscapularis. Now then we have the most important muscle, that is supraspinatus. They ask you various questions from it. This is supraspinatus and this is our acromion. This is our acromion. And this is a very common scenario for painters and all those that do overhead activities. They get impinged. They impinge their supraspinatus. They impinge their supraspinatus. And this is the most common muscle affected in shoulder. Most common muscle. If they say rotator cuff tear, rotator cuff tear, mostly it is supraspinatus tear. Most of, like 90% cases, 90% cases, this is supraspinatus tear. What are the various scenarios we will have? I will tell you in our note. Just see the muscles now. This is infraspinatus and this is teres minor, TM. So these four muscles are your rotator cuff. One, two, three, four. Or you can just mark supraspinatus one, two, three, and subscapularis four, as it's in the opposite side, whichever you prefer. But that's not important. All you need to know, where is what. Now, let me briefly tell you the movement. Initiation, that means starting of the movement, is done by starting supraspinatus. Supraspinatus 0 to 15 degrees. So if anyone cannot start shoulder abduction, shoulder abduction, so that's supraspinatus injury, or that's a problem in supraspinatus. Then after 15 degree, it is done by deltoid up to 90 degree. Above 90 degree, it's at the top. Your hand is at the top. Hand is at the top. This is trapezius. This is trapezius. Hand is at the top. This is trapezius. Okay, top trapezius. Top or over 90 degree. Up to this is deltoid. Up to this is deltoid. Now you will always have questions from here. Like they will tell you a person came to you and he cannot start. Mostly they use the word initiate. Initiate shoulder abduction. Which muscle is injured? Number one. Which muscle is injured? We know supraspinatus. Number two, the injured muscle. They may not mention the name. The injured muscle is supplied by suprascapular nerve. This is the second question. And they may not mention any of this. They will say the injured muscle's nerve supply comes from upper trunk. Upper trunk. Just remember this. Now, then, impingement, frozen shoulder, painful arc syndrome. I will tell you in note. Guys, now we will talk about radial nerve. But before that, I'm going to show you the spaces behind the scapula. Okay. Just see it. We have it all in our note. All of it. So remember, here we had triceps. Just drawing a line. Here we had triceps. So this is our quadrangular space. This is our triangular space, and this is our triangular interval. Guys, okay, so with quadrangular space, remember quadrangular coord, A for axillary. Remember A for axillary. Triangular space, not important, doesn't come, so I'm not mentioning it now, but we have it in our notes. I will show you. Triangular interval, remember inter, R for radial. Remember, radial nerve comes out through triangular interval. Okay. Now, this is about the nerves. Now, I'll add the artery and just two arteries, guys. Just see it now. And you will be able to remember it totally when you see in the note. This is our circumflex humeral artery. Now, we are seeing it from behind. So it's posterior. We have an anterior, not important right now. Just remember circumflex humeral artery. So with quadrangular space, we will have circumflex humeral artery and axillary nerve. Now, and with triangular interval, we will have radial nerve and arteria profunda brachii. Okay, we will have radial nerve and arteria profunda brachii. Profound means deep. Deep, like when someone says something very deep, what do we say? This is profound. Profound knowledge, deep knowledge. So profunda just means deep. And important thing is they will ask you that how radial nerve comes. Radial nerve comes out from posterior through triangular interval, goes through spiral groove, and then comes in front of your lateral epicondyle. Let me hide brachialis and we will see this is our radial nerve which is above our lateral epicondyle. They will give you three fractures from humerus. Number one, surgical neck fracture. Number two, lower one-third fracture. And number three, supracondylar fracture of humerus. Remember, in case of surgical neck of humeral fracture, the two structure you have seen in quadrangular space, that is axillary nerve and your circumflex humeral artery will be damaged. If circumflex humeral artery is damaged, see, circumflex humeral, it goes like this, and gives branches to humeral head. So if here we have a fracture, we will have avascular necrosis of humeral head. Okay, then if we have middle lower one third of humeral fracture, remember the closest nerve, the closest structures are two. That is arteria profunda brachii that ends almost nearly half of the humerus, and this continues. So in lower third, this is so close to the bone. See, it's just above the bone. So radial nerve will be injured. Okay, guys, I got a crash. So radial nerve is very close, almost over the bone. So in lower third of humeral fracture, radial nerve will be the most common structure to be injured. Then again supracondylar fracture of the humerus. Guys, see, in case of supracondylar fracture of the humerus, see, in case of supracondylar fracture here, radial nerve is almost far away, very far. And this is the supracondylar area. And according to according to the displacement, we will show you that all three nerve can be injured. All three guys. What are the three? Radial, median, ulnar. Radial nerve, median nerve, and ulnar nerve. Radial is in front of your lateral epicondyle. Median is just above it, coming down. I'll show you the course. We have shown it in anatomy, still just a recap. And ulnar will be behind. Ulnar will be behind your medial epicondyle. See the gap, very close, guys, very close. And this one is our median nerve. It's coming from above and it comes close during our supracondylar area. Now, what happens? Now, what happens? The most commonly injured nerve here is median nerve. Median nerve is the most commonly injured. Now, median nerve is the most commonly injured found in clinical practice and because of its anatomical position. Okay, so most commonly structured nerve, median. Then, if they don't give median, they will give you anterior interosseous branch of median. Simple as that. Simple as that. Just to make you confused, nothing else. Just so you know that AIN is a branch of median nerve. Okay, but ulnar can be injured too, and radial least commonly injured in supracondylar fracture, but can be injured depending on the displacement. I'll show you the displacement. Don't worry about it. Then they will ask you about anatomical position of median nerve. We have talked about it. Not important right now. See, let's go on to wrist. What are the things? What are the things they will ask from orthopedics in your wrist? Guys, see, this is our scaphoid bone, and most important bone. Almost, I will say, if you just study one bone from your wrist bones, learn the scaphoid. And what are the things you need to know from scaphoid? Scaphoid, it's arterial supply. See, this is our radial artery. This is our radial artery, and what happens? Just a tiny branch. See this? Just a tiny branch is given to scaphoid. Just a tiny branch is given to scaphoid. Just one tiny branch given to scaphoid from distal end. From distal end. Okay. And see which one is the most commonly or high risk of AVN if there's a fracture. Of course, proximal pole. This is the thing you need to know. Proximal pole. Okay, the blood supply is coming from distal end. First thing, first point, blood supply coming from distal end. If there's a fracture of distal end, which pole will undergo avascular necrosis? See, it will lose its blood supply. This area will lose blood supply, and this will be proximal pole. Proximal pole will go under avascular necrosis. Very simple. This is the thing you need to know. Then, second thing from wrist. Second thing from wrist. And okay, let's just hide the arteries for now. And then nerves too. Okay, let's just leave it. Okay, so how do you know that you will have a scaphoid fracture? What are the signs and symptoms? Remember, see, this is the thumb. This is our thumb. Now, in thumb, if you apply pressure 90 degree, if you apply pressure 90 degree, you will have pain here. This is our anatomical snuff box, guys. You will have pain here. You will have pain here. Let me show you with my pen. You will have pain here. So this is our anatomical snuff box. Okay. This is our anatomical snuff box. You will have pain. See, you can see it very clearly. Uh, 1 minute, guys. So here you will have the pain. This is the snuff box. This is the snuff box. You will have pain here if you press over thumb 90 degree, or you press this area over anatomical snuff box. Yeah, and that patient will feel pain. And this is our sign for scaphoid fracture. Now, this may or may not be present in X-ray. You can find it in X-ray, or sometimes you can't find it in X-ray. So what do? You do MRI. We will talk about that. Just remember this, that if you give apply pressure 90 degree over your thumb, you will feel pain here. So scaphoid is fractured. Or you press over anatomical snuff box, you will feel pain here. So it's scaphoid fracture. Simple. What do? Give a future splint. Okay. Then, and they will ask you about the boundary of anatomical snuff box. See, remember, in thumb we have two phalanx, one first phalanx and second phalanx. Others we have three. So this is our metacarpal, and this is our metacarpophalangeal joint, MCP, and this is our IP joint, only one. Now remember, at the base of first phalanx of thumb, we have one muscle attached. Just I will tell you the names. And at the base of second phalanx, we have one, of course, tendon, but one muscle, I will say, one muscle attached. Okay, so the muscle that is attached here, so the muscle that is attached here at the base here, it will it will extend this joint. So this is our IP joint of thumb, and the muscle that is attached here at the base of first phalanx, it will extend metacarpophalangeal joint of the thumb. Simple, simple, because if it pulls, this one will be extended. If this area is pulled, this area, so this joint will be extended. Okay. So see, this is our IP joint. IP joint is extended by this tendon. See this tendon? IP joint is extended by this tendon. See this one. This is our extensor pollicis longus tendon. This is our extensor pollicis longus tendon. And you will find a question that a person cannot lift thumb if the palm faced, see, if palm faced downward, so feel like this is down, a person will be extending this IP joint or lift the thumb above. See, I'm lifting the thumb above. And which tendon you see? This one. And this is our extensor pollicis longus tendon, which is attached at the base of second phalanx of your thumb. Okay, this one. Now, if I want to make it 90-degree, so lifting thumb above the surface when palm faced downward. So this is, if this is down, you are looking from above. So if this is down, you are looking from above, you will see that to lift this finger, this tendon appears. So this is our extensor pollicis longus tendon. Now remember, every muscle in a joint will have an opposite supply too. If I have to extend like this, I have some muscle to flex it like this. So if this joint is extended by extensor pollicis longus, that is this one, it will be flexed by flexor pollicis longus, that cannot be seen that way. It will be flexed by flexor pollicis longus. Okay, guys. So if palm is faced downwards like this is the downside, this is the upside. Palm is faced downwards, and the person cannot lift his thumb above the table and cannot extend IP joint. So our extensor pollicis longus tendon is injured, or its nerve supply has gone somehow. Okay, then flexor pollicis longus, it will flex IP joint. Okay, it will flex IP joint. It will flex IP joint, and it is named flexor pollicis longus. And they will tell you palm faced upwards, and person cannot palm faced upwards lift. This is the lift. This is the lift. Okay, lift. This is the lift. Person cannot lift. So now this time palm is facing on your side. That means upwards. If you can't lift it and cannot flex the IP joint, if you can't lift it and cannot flex IP joint, that means flexor pollicis longus is paralyzed, or flexor pollicis longus tendon is injured. If you can't make it 90-degree, if you can't make 90-degree, so see, you cannot make it 90-degree on extended position. It's hard. Okay. If you cannot make it 90-degree and palm is face on your side, then flexor pollicis brevis is injured. If you can't flex IP joint, flexor pollicis longus is injured. If you can't flex metacarpophalangeal joint, that is this one, these are metacarpal and these are first phalanx. So metacarpophalangeal joint, if you can't flex it, you cannot make the thumb 90 degrees. See, this is 90 degree. This is 90 degree. You cannot make it 90 degree if flexor pollicis brevis is injured. Okay. These are the questions you are going to get in your exam. Okay. So, and this is our abductor pollicis brevis. This is our abductor pollicis brevis, which is attached on the base of first phalanx. This will cause abduction. This will cause abduction. Abduction of the thumb. Okay, just anyway, let me show you the boundary of anatomical snap box. We have it. We have it in our. Don't worry about it in our notes. We have it all in our notes. Okay, so this is our anatomical snuff box. This area, this place, this is our anatomical snuff box. Okay, so this is one tendon, This is another tendon which is making the boundary, and this is the third tendon. Okay, what did I say? Be very careful. This is the third tendon. So it will be in third extensor compartment, and it is our extensor pollicis longus tendon. Then, then we have, let me show you. Then we have extensor pollicis brevis tendon, which will make the thumb 90-degree when palm faced downwards. Mark my words. When the palm faced downwards, or extend MCP joint. Extend, extend. Then, then we have, of course, let's not go there right now. We'll go later. Okay. And this is our abductor pollicis longus. Okay. Abductor pollicis longus, this one, and extensor pollicis brevis and extensor pollicis longus. Remember, this is the medial boundary and this is the posterior boundary, both. And this will be the lateral boundary and this will be the anterior boundary, both. Okay, so we have it. Don't worry about it. So these are the things you will be needing. And then from fractures, we have shown it, all of it in our anatomy. So we will not go into these details right now. Just the things I have shown you, and we will in our revision classes we will show you again. So you already know it. Don't worry about it. Then we will go to chest, and I'll talk about stab injury. I have talked about it in thorax, still just a recap. Okay, let me remove the muscles. This is very easy. Let me mark it. They will give you this place. They will give you this place. Sternal angle. They will tell you stab at sternal angle or just below sternal angle. Okay, that means it's second intercostal space. Which side? Mostly they give right side. Just hide it, and we can very clearly see in this whole area, from sternocostal joint of second rib and up to almost all second intercostal space, we have one thing, that is right atrium. So right atrium will get injured. Then if we go lower, after second intercostal space, that is third, fourth, fifth is very low. So third, fourth, if right side is stabbed, or left side is stabbed along sternal edge, or sternum itself is fractured, the only one organ will be injured, that is our right ventricle. So 3, 4, 3, 4. Sternum fracture, or along the edge of sternum, if there's a stab, right ventricle will be injured. Always, always, always. In case of 5, sometimes heart has ended, so your answer will be pericardium or fibrous pericardium. If the stab is along sternal edge, now if it's fifth intercostal space and you are stabbed in mid clavicular line, your apex will be injured. Only in that case, mid clavicular line, apex will be injured. Then we go lower. Let's remove the arteries so we can see it clearly and add some muscles. They will give you femur fracture, neck of femur fracture. We need some arteries for that. They will give you neck of femur fracture. See, this is our lateral circumflex femoral artery. This is our medial circumflex femoral artery. This is our iliopsoas tendon. First question: iliopsoas tendon attached in lesser trochanter. First thing. So when you release lesser trochanter, you release iliopsoas tendon from lesser trochanter, medial circumflex femoral artery is the one that is most commonly injured. And what happens if that's injured? It will give branches to femoral head. It's a large area, guys. It's a very large area. Femoral head. Now, if in any case we have neck of femur fracture, that is NOF, neck of femur fracture, this supply will be disrupted and we will have avascular necrosis of femoral head. Okay, we will have avascular necrosis of femoral head. And during iliopsoas tendon release, see, medial circumflex femoral artery is very close. Lateral is far away. All lateral is far away, guys. See, lateral is very far. Very far means if you compare with medial circumflex femoral artery, lateral is very far. So this is the most commonly injured. Then you will have questions from neck of femur fracture. You will always have questions from neck of femur fracture. I will talk about that. Don't worry about it. Then we go lower. Then second fracture is supracondylar fracture of the C. Okay, next. Next we have adductor canal and lower third of femoral fracture. In case of lower third of femoral fracture, remember femoral artery is at risk, is at very risk. Femoral artery is at a big risk. So they will give you a scenario that a person had lower third of femoral fracture and now lower limb is cold. So that's an arterial disruption. That's an arterial disruption. What do? They will just ask you, what's the problem? That's an arterial disruption. We'll talk about it. Don't worry about it. Then our very, very important, we already have talked about all these in our anatomy classes. Still, I'm going to recap a little bit so you get the idea. At the veins, at the nerves. So then this area, popliteal fossa, very important. Popliteal fossa, you will have questions from popliteal fossa. Let me show you something. Something boundary, you have it. Don't worry about it. Just see it from here. I'll just show you the important questions. Okay, let's just remove some muscles. So see, this thing I wanted to show you. That is, this is our tibial component of sciatic nerve. This is our common peroneal component of sciatic nerve. And tibial is the most superficial structure in popliteal fossa. If they ask you which one is the most superficial structure in popliteal fossa, or which one we will encounter first during popliteal fossa exploration, the answer will be tibial nerve. And this is the serial, you can see it very clearly. This is the serial, you can see it very clearly. So this is our tibial nerve. This is our popliteal vein. and this is our popliteal artery. Femoral artery, the moment it passes a ductal canal, it becomes popliteal artery. So popliteal artery is just above your bone. See, popliteal artery is just above your bone. Just above your bone. The vein is in the middle, and tibial is most superficial. Just you will say, you just open the skin and fascia, and you will see tibial. Okay, so this is the serial. And when you cut the bone with a saw, you have already secured these two structures, right? You have already secured these two structures, and the artery is the artery is the structure that is in risk of injury here. And you will get this question that during cutting the bone with saw, which structure will be injured? Artery will be injured because you are too deep. You are too deep near the bone, and we have near the bone the artery. Then about Becker's cyst, guys. See, just remember these two things. We have it. If they ask you about posterior approach, see, this is the direct posterior approach, and tibial nerve is at risk. If you approach from posterior medial side, if you approach from posterior medial side, you have to approach it through this area. So you have to secure this nerve, that is our saphenous nerve, because we have to enter through this area. You have to enter through this area posterior medially. So you have to secure your saphenous nerve. Okay, so in posterior medial approach, be very careful during the recent studies. Be very careful about saphenous nerve. Okay, see, then about some say sural, guys. See, and they just don't know. That's the problem. They know sural can be injured too, but see, sural sural we have two heads. Here we have lateral sural cutaneous nerve, and here we have medial sural cutaneous nerve. Okay, here we have lateral sural cutaneous nerve and medial sural cutaneous nerve, and it the main sural nerve is formed by these two, and almost after gastrocnemius it starts, but anatomical variations are present. Anatomical variations are present. Okay, so in case of posterior lateral approach, though this is very uncommon, there is no posterior lateral approach. If you don't have tibial in your option or saphenous, it's not posterior medial approach. In posterior medial approach, be very careful about saphenous nerve. Okay, and in posterior approach, tibial nerve. But if tibial is not in option, look for sural. Only if tibial is not in option. Okay, then then you will. I need to show you the collateral ligaments. Okay, let me show you the ligaments. Turn off the arteries, veins, nerves. We don't need it right now. We just need the ligaments. Let me show you. We hide it. Okay, see. First, we will remove the patella. We hide it. See, now you can see. See, this is our knee joint. First thing you need to know is the collateral ligaments. Let me just draw it. This is our medial collateral ligament. This is our lateral collateral ligament. Remember, these are like boundaries. These are like boundaries. If this side is broken, knee will bend to same side. If this side is broken, knee will bend to same side. Same side, guys. Okay, so if lateral collateral ligament is injured or medial collateral ligament is injured, if lateral collateral ligament is injured, knee will be bent on outside, lateral side. or we will have a varus deformity. Okay. If medial collateral ligament is injured, knee will be bent medially, knee will be bent inside, or knee will be unstable in medial side or inside, or valgus position. Valgus position. Okay. Then just see the cruciate ligament. See, let me show you from. Let me just remove the femur for now. See, it's coming from anterior and going behind. So this will be your anterior cruciate ligament, and this is your posterior cruciate ligament. Okay, so it holds the femur from anteriorly. Okay, and it holds the femur from posteriorly. Now, actually, not femur, both femur and tibia. Now, and these are your menisci. Menisci. Remember, menisci are less vascular. So when you have a meniscal tear, you will not have much bleeding, or you will have swelling, but the swelling will be delayed because it is less vascular. But if a cruciate ligament is injured, knee will be immediately swollen. These are all less vascular structures, so swelling is mentioned, but hemarthrosis you can have, but most commonly swelling is mentioned because knee swells immediately. Remember, these looks like I and these looks like D. So menisci will have delayed swelling and cruciate ligaments will have immediate swelling. Okay, these are the clue. I will talk about it. Don't worry. Then nothing much from here anymore, but some important ankle ligaments. Let me show you. Let me just show you from this side, from medial side. Okay, these are a lot of ligaments. You don't need to know that. Just remember deltoid ligament medially. Deltoid. Deltoid ligament medially. And remember, here we have also a lot of ligament. Just remember anterior talofibular ligament. Okay. And this one is also anterior talofibular ligament. And these are the most commonly injured structure in an inversion injury. Inversion injury. In case of inversion injury, these things will be super stretched or hyper stretched. See, these things, if ankle joint, if palm goes in, if palm faces inside, this thing will be stretched too much and it will be injured, and that's the most common structure injured in ankle, of course, and in case of inversion injury, most commonly injured structure. Now they will give you a scenario. It's an investigation scenario that a person had an inversion injury. X-ray showed no fracture, but pain doesn't go. So what will you do? You do MRI because ankle, mostly ligament is injured in ankle. Then almost all of the important things I have shown from orthopedics, the things you will have. And remember, second metacarpal fracture. Second metacarpal fracture. Of course, third can be fracture too. That is called soldier. That happens in soldier mostly. Happens in soldiers, and these are called march fracture. These are called march fracture. Okay. And Morton's neuroma, that's a neuroma. So we will talk about it. Don't worry. Okay, almost all of the things I have shown you, all the important things I have shown you, nothing missed. Guys, nothing missed. If there is something else that is important for your exam, I will show you it later. Okay, guys, let's go in our notes. Okay, guys, starting with our notes. I mean, force to valgus side, knee bend medially, knee bent valgus side. All of it is medial collateral ligament injury. Okay, medial collateral ligament injury.